everyone. We'd like to thank you for joining today's webinar on Division Directive 4.300 and Draft Behavior Support Rule Part 2. I'm John's Learning and Development Coordinator for the Division of Developmental Disabilities, and I'll host for today's webinar. As always, I'd like to begin with just a few housekeeping items. Participants are muted upon entry. However, we do suggest that you mute your line as well. Remember that you have the ability to control your viewing of the presentation via the navigation tools on the top right of your screen. If you have questions during the presentation regarding content, we ask you to use the Q&A box. If you have technical questions, please use the chat box for those, and we'll help you to the best of our abilities. Recording of both Part 1 and Part 2 will be available later this week, and a link to those recordings will be sent out via a Division email blast. If you aren't signed up to receive those Division email blasts, you can do so by going to the DD website. On the right side of the screen, you'll see a yellow box that says Get Email Updates. If you click on that box, it'll take you to the registration page. At the completion of today's webinar, there will be a brief survey that'll open in your window. We encourage you to please participate in the survey as your feedback is important to us. And those housekeeping details taken care of, I'll now turn it over to today's presenter, Dr. Terry Rogers, Chief Behavior Analyst for the Division of Developmental Disabilities.
Good morning, everyone. To continue on in the housekeeping mode, I want to have you note that the information on how to print out the materials is on your in chat box there, and you can get to that hyperlink and print out materials. Materials are for both Part 1 and Part 2. So if you need the materials, please do that. And just a few things to review. I will not be teaching you how to do applied behavior analysis today, but I will be going through some of the recommendations and requirements that the division has for service providers who are part of a team in which behavioral services are utilized, or behavioral service providers. So please, if you're expecting to be taught how to do behavior analysis, that is a much more extensive training, and it will not be happening on this webinar. Something that I wanted to address up front here is that directive is the policy and procedures for the division, the agency, the Division of Developmental Disabilities. And a rule is something that goes through governmental process to become law, and the draft rule is in the process to do that. So at the time that it becomes law, then it will be mandated and will be able to be enforced through all of the processes that can happen when the violation of the law. So just to clarify for folks, we had some questions last time about the difference between a rule and a directive. Session, we went through prohibited practices, and we went through bits of restrictive, reactive, and rights restrictions. And you can review those concepts in the Part 1 materials. Part 2 is going to go through expectations for planning teams. These are the support teams who are supporting individuals. Going to go through the expectations for the area behavior analyst and the regional offices around behavioral supports. We're going to review the role and the function of the Regional Behavior Support Review Committee. So if you haven't heard of these, that would be of particular interest to you. And I'm going to provide you some information about the special review process that will be followed if we discover possible use of prohibited practices. I'll also be going through some requirements and suggested processes around safety crisis plans, but this will not be a whole safety crisis plan training. That is available on the webinar page. And we'll go through some requirements for behavior support plans. So that's what we're going to try to get through this morning. If you have any questions for me around material, please put those in the chat box. and I'll attend to them as I can during the presentation. Not the Q&A, sorry. My hostess just pointed out the chat box, the Q&A box, sorry. And then the chat box is for any questions that you have around technical issues that Heike can address for you. And I wanted to mention, there will be polling questions throughout this presentation, and we'd really appreciate your participation in those. That helps me to see if I've been clear in my presentation, if there are concepts that maybe need further explanation. So please participate in the polling questions when those pop up. Okay, so now let's get started. So I'm going to be going through the directive and draft rule, and I just want one more caveat for you all. This does not take the place of you reviewing that material yourself, and as always, it's recommended that stakeholders to the language as written in the directive and the rule for exact information. So I'm just going to be going through that for you. That doesn't take the place of you reading it yourself. What is the planning team or the support team? A lot of times when or the applied behavior analysts, area behavior analysts that are in the regions, they're about what the planning team is. So if you could give us a little, and we'll see how people are doing with understanding what the planning team is. So go ahead, and I'm going to wait a few more minutes. Any of you still need to answer? Okay, so some of you answered. I hope that participation increases as we move along here, because it really does, one, make it more meaningful for you to have to do active participation. As we know in behavioral sciences, active participation or active behavior is a better learning modality. But the answer to what is the planning or support team is all the people involved with supporting the individuals, including support coordinator, the residential or day provider, the guardian, the individual, the family of the individual, and anyone else the individual chooses are the people that make up that planning team or support team. So that was your answer. Very good. And we're referring to the planning team throughout this training. Here's a reminder. In the first session, we went through the reactive strategy threshold, and this is the threshold that has been set that says the planning team must do something once you reach this threshold with use of reactive strategies. And threshold is applied to all reactive strategies that also meet the definition of restrictive interventions. So if a person has experienced 5 or more of these restrictive reactive strategies in a 1-month period, then that threshold is reached and the planning team has activities that they have to go through. Don't wait until you need reactive strategies to do something. That's the real underlying message to all of this. We're trying to set up best practices for everyone to understand that there's things you have to do when you are experiencing reactive strategies, but it's best if you can print reactive strategies, and that's done through really thorough, person-centered, positive planning and making sure that everyone's implementing those strategies, those positive preventative strategies ahead of time. So this is a scheme actions that are specified for service providers when reactive strategies are to be necessary. So the purple box shows you that you're implementing and monitoring the use and the effectiveness of positive proactive strategies, that you've developed a process to review reactive strategy use. So anytime you have to use a reactive strategy, especially if it's a restrictive strategy, your team should have already set up what are we going to do afterwards to review the use and see if it was used effectively, if it was used appropriately, if there's anything we need to change, if it worked the way we wanted to, all those kinds of things. Make sure that everyone knows that we're not allowed to use prohibited procedures. That's very important. So that's an ongoing process you've set ahead of time. But like something happens, you have to use a reactive strategy, or a reactive strategy is considered likely and necessary for somebody. Then the team consider, are there specialized services that might help in this situation, that might help it so that we don't have to use reactive strategies? Maybe some needs aren't being met. So secure other specialized services. And if you think you have to use reactive, restrict strategies, you should create a safety crisis plan beforehand so one knows what to do, and you're not leaving the family or the direct care staff trying to figure out what to do in the middle of a crisis. So after the team's done that, they should consider if manual restraints like holds are likely to be necessary with this individual. And you know that because of their past history. Past history is the best predictor of future behavior, all things being equal. And the type of behavior that are likely to occur, how behaviors are learned and reinforced. It's likely to use or need to use some kind of manual hold or physical intervention to prevent dangerous behaviors, then all staff need to be trained in that physical intervention system. And everybody needs frequent review of those restraint practices or holds as their reactive strategy planning, and you should indicate the criteria for use in your safety crisis plan. If that's necessary, you've trained all of your staff in the system that your agency is using, and now you're providing services. Use reactive strategies that are restrictive for an individual, and you reach the threshold, then the planning team has to undertake an extensive review. Now, this isn't something that the state is monitoring. I'm going to come and tell you you need to do this. That's part of your review strategy responsibilities, that you're monitoring this and you implement this as you reach the thresholds. Within 5 business days, the team reviews the triggers. Did we do the preventive strategies? Were there barriers to use of these? Less restrictive strategies? Do we need to have other services like a functional behavioral assessment or behavior support plan? Do we need to revise the behavior support plan? Should revise the safety crisis plan? The team needs to go through an active review process of the incident and what could that the incident or incidents like that don't happen again. If individual reaches the threshold for 3 consecutive courses in 2 years, then the team has to request behavioral services. So no outside force is going to come in and look to see that you're doing this or prompt you to do this. However, should a situation occur where there's a review after the fact and this hasn't happened, then you would have not met your obligations as a service provider. That's the specifics for the providers for reactive strategies that are also restrictive. It goes to preventing them, doing a safety crisis plan, considering if you need physical holds and training folks in those strategies, and monitoring internally your restrictive, reactive strategies, and holding a review if you do have to use those and you reach the threshold. So, some emphasize is that even before using reactive strategies or restrictive interventions, the providers are required to have trained staff in positive supports and ensure that staff are implementing or using those positive supports. So initial training is not enough. You need to ensure that staff continue to use those approaches. Positive approaches need to be documented in the individual support plan. The individual support plan needs to be implemented, used. And part of the responsibility of the service providers and the support coordinator is to review and ensure that those strategies are being used. They need to be assessed. There's supplemental questions in the ISP guide to help you do that needs assessment, especially if the individual has a history of dangerous behavior or challenging behaviors that have the potential to be dangerous. Then they need a safety crisis plan. Service coordinators should be utilizing all resources available to them to assist in this process, especially when not sure what to do or things get difficult. And this includes the due process committee and the regional behavior support review committee. So utilize those resources if you need or if you're getting stuck. So again, before the reactive strategies are used, the provider should have staff trained in a division-approved crisis management system if a needs assessment or the individual's history identifies that an individual is likely to or has the potential to need that level of intervention or physical intervention to prevent dangerous behaviors. The provider and the planning team should be collecting and regularly reviewing data that they use to guide their decision-making on whether the ISP strategies are working, their preventive strategies are working, and safety crisis plan is working. And providers should be developing a process to review those reactive strategies that are restrictive or intrusive, and that should include documenting that this review has occurred in relevant incident report. Okay, so rules also apply to self-directed support situations. Yes, these are really rules to make sure that we have the possible situation of supports for the individual, the safest possible things happening, and that the individual's staff or the family supporting the individual are aware and prepared to address the situation and the individual as best as possible. So there would really be no situation in which these aren't appropriate. Yes, they apply to people in self-directed supports. All right. So that question. So again, when you use one restrictive reactive strategy, that's your cue that you should, if you haven't before, developed a safety crisis plan. So the planning team needs to be very aware of what's happening in the day-to-day life and support of the individual. And they need to be aware through documentation and data review and discussion with all of the individuals supporting and working with the person when restrictive intervention has been utilized. And if you don't have a safety crisis plan, you don't want people out there running rogue and doing whatever in the middle of a crisis. You'd like to give them some guidance about what would be the best thing to do, and that's what the safety crisis plan does. So if you want to see, you want more information about safety crisis plan development, there's a safety crisis plan webinar, and attachments that are included with the Directive 4.30. One of them is the safety crisis assessment, and the other one is a template for safety crisis planning. Doesn't have to be used, but it will be much easier to write a safety crisis plan if you do look at that template. But I recommend teams be proactive and consider if they need safety crisis plans before they're necessary, and consider if other specialized support strategies would be of assistance. Our restrictive, reactive strategies, they'd be monitoring and evaluating their effectiveness. Okay, our second polling question. Really like to get over 50% of you responding to this. Who tracks when a provider meets the threshold for a person? When a provider meets the threshold for restrictive strategies, who's tracking that? Okay, well, most of you answered this one correctly. The answer to who tracks when a provider or support people meet the threshold for reactive strategies that are also restrictive is C, the provider whose staff uses the restrictive strategies. So the office is not going to be tracking that. The PR unit for the regional office is not going to be tracking that. Of course, the Guardian's not going to be tracking that. They're not there. And the support coordinator will probably want to be monitoring to make sure that happens and that they're involved in that discussion when the team goes through a review. The only person who's really, or the only people who are really going to know when restrictive interventions are used is, of course, the people using them. So that is C. The requirements for a planning team when the threshold is met. So when reactive strategy thresholds met, the team has to, if they haven't before, develop a process for reviewing those reactive strategies. And they should think of, do we need other services here to help this person? Because we don't want to keep meeting this threshold. We don't want to keep using restrictive, reactive interventions if we don't. There are things that we could do to prevent them, because we are a preventative, proactive, positive system, and that's what we want to try to do. So our behavioral services is appropriate. Would that be a good thing to use? Is counseling necessary? Have we had a good medical review? All of these are the kinds of things that the team needs to go through and really give some critical consideration to. Some other considerations are that if you've met this restrictive reactive strategy for 3 consecutive quarters, then the planning team must refer to the Regional Behavior Support Review Committee for consultation. So the Regional Behavior Support Review Committee is made up of professional behavioral providers from the community, and they provide consultation on strategies and considerations that the team could make, and we want that to happen when there have been 3 consecutive quarters of restrictive, reactive interventions that meet the threshold. Thresholds met for 3+ quarters in a 2-year period, then you must request behavioral services. You'll notice it doesn't say you have to get behavioral services, you have to receive behavioral services, but you have to request them. The reason we've written that way is we understand there is a shortage of behavioral service providers, and there's sometimes a long wait to get those in place, but we still have them requested and secured as soon as possible. So if you meet that threshold in 3 quarters or more in a 2-year period, you must request behavioral services. At this team meeting about restrictive reactive strategies when you reach that threshold. So there's a heightened review by the individual's support team, and what they do in that heightened review. Well, they consider are the right strategies in plan. So is plan, safety crisis plan, individual support plan, behavior support plan if you have one, are those the right strategies that we should be using, are being used consistently and correctly? So the diet your doctor gives you that you never follow is not going to work if you don't follow it. So are you ensuring that everyone's been trained correctly? Are you going back through and making sure that everyone is using those strategies as they're supposed to, when they're supposed to? Do you have elected to tell you, are they working? And then they are, have looked at other things that could be a problem. There are a lot of medical problems that can manifest themselves as behavioral problems, and sometimes you wouldn't think that that there's a full issue even when there is. So you could have an undiagnosed seizure disorder, you could have UTI, you could have somebody with a sinus infection, you could have constipation. Those are just some common medical issues that people don't recognize that can cause behavioral problems. Sometimes if an individual's on antibiotics, they can react to that and have behavioral problems from that reaction. It could look like psychosis, it could look like other problems. If they're not sleeping, that can also cause a problem. So we should look at, is it a medical problem that's possible? Are there environmental changes that could prevent the episode? So could there be a visual schedule? Could we rearrange, this is a night person and we're trying to get them up early in the morning, can we rearrange that? Other needs for services to assist. Do we maybe have somebody who mainly utilizes a system, but our staff aren't trained in using the PEC system and they're not consistently using it? You should pick that up in, are your strategies being used consistently? And you might need to get some assistance in there to train your staff in how to use the PEC system or sign language or something like that. Consider what the quality of life is for the individual and what can you do to improve it. So if people don't have a meaningful day, if they don't have positive relationships, if they don't have a role that makes them important in their own life, in the lives of others, if not healthy, if they don't have choices that are meaningful, their quality of life is impacted. So you might need to look at that and see what you can do to improve the individual's quality of life. And basically, what could change in the plan and the strategies to make the reactive strategies less likely to be necessary in the future? So that's the point of that review process that's done by the team, and it should be a very critical, not mean, but very critical, objective kind of review. And you should consider the need for functional assessment and behavioral services if behavior problems continue. In question, what's the purpose of that team meeting when the threshold is reached? And this is one where you choose all that could apply. to meet the individual's needs. That was that, and we all are trying very hard to do that. In the support coordinator is responsible for documenting the assessed need that requires the use of reactive strategies, especially restrictive reactive strategies in the ISP, and that they are responsible to periodically review with the team the ISP and those strategies that are documented, and they document that in their monthly summaries. The support also is responsible for making sure that the ISP documents less intrusive and restrictive interventions have been attempted and the outcomes of these interventions. So there's some specific things that are within the support coordinator's responsibilities, and a lot of times they're fulfilling these responsibilities with the full support team being part of that discussion. The support also, of course, has to obtain individual and legal guardian informed consent for the use of those restrictive reactive strategies. They facilitate the planning team development of the safety crisis plan, and they create the document. So the physical document is created by the support coordinator, just like the physical document of the individual support plan is created by the support coordinator with the planning team. And they, with the team, regularly assess the needs of the individual and refer for additional services to address problems if the individual support plan and the crisis safety plan strategies are ineffective, or if reactive strategies, especially restrictive reactive strategies, are frequently necessary. The support coordinator also has some quality assurance responsibilities. One of those is to be sure that the service providers are able to meet the needs of the individual as documented in the ISP. They also monitor implementation of those ISP strategies as in the ISP and in the crisis safety plan. If there is a behavior support plan, they're part of that monitoring to make sure that those strategies are implemented as they're designed. They're also, as part of their quality assurance responsibilities, making sure that the individual is afforded all rights and that restrictions or modifications have received due process. Just a reminder that due process happens at the level of the individual support plan team and the services that are provided, not at review committee, process review committee. Due process review committee is only looking to see that due process has already been assured to the individual. So that going to that committee is not due process. That's due beforehand is due process. The service coordinator or support coordinator is making sure that extra check to make sure that prohibited strategies are not used, and that if the reactive strategy threshold is reached, the planning team meets to do that review that we just discussed. And they're also assuring that those restrictive reactive strategies, if used, cause no harm to the individual, and document the planning team assessment of this. Has some responsibilities in supporting the providers and service coordinators. So the regional office responsibilities include providing ongoing training and consultation that promotes positive, restrictive strategies, such as person-centered approach, the tool of choice, if you've heard of that training. And for providers, we have a process of consultation that's called the tiered supports process. And the purpose of these is to ensure that there's training and consultation available to promote positive and least restrictive strategies for all of the service providers. The regional office is also providing access to and make sure that utilization of committees such as the Regional Behavior Support Review Committee, Process Review Committee, individuals, they are responsible for referring individuals for review, as well as ending these committees. Also, responsible to make sure that there's availability of consultation with the region's area behavior analyst for individuals that are identified as high risk, and they monitor all of the policies and procedures and processes and through the licensing and certification unit, the relations unit, and the quality enhancement unit. Okay. Yeah. Behavior analysts. There are 3 area behavior analysts in the state, and they are affiliated with 4 or 5 regional offices each. The Eastern Area Behavior Analyst is Melantha Witherspoon, and she is located physically in the St. Louis region and is responsible for Hannibal, St. Louis, and Sikeston. The Central Area Behavior Analyst is Lucas Evans. He's physically located at the CMRO office and is responsible for Kirksville, Morrow, and Poplar Bluff regions. And the Western Area Behavior Analyst is Rita Cooper, and she's responsible for Albany, Kansas City, Springfield, and Joplin regions. So those folks have some responsibilities related to all of these processes also. One of those is to review the data for individuals that indicate they have high-risk outcomes. And do this quarterly, and they look at data. They come up with individuals who are meeting those risk areas, including law enforcement involvement, psychiatric hospitalization, psychotropic medications above the threshold, emergency procedure use, and frequent moves in our system. So those are all high-risk outcomes that they look at, and they do it by individuals who meet multiple outcomes. They look at that data in terms of providers who serve those individuals, in those providers, with the individuals, with the region, and they are developing and implementing a lot of strategies around trying to address those outcomes and reduce those as problems for individuals and for providers. Part of that is to chair the Regional Behavior Support Review Committee and invite individuals who meet those high-risk criteria to that committee for their support planning teams to receive some consultation around other things that might be able to be done to prevent those outcomes. The incident reports, other information for potential use of prohibited procedures, and when they discover that there might be a prohibited procedure, they implement a special review process to assist the planning team in utilizing less restrictive strategies. And there are some timelines and the directives that they have to meet. We're going to go through a little bit about safety crisis plans. Again, this will not train you thoroughly in developing or implementing safety crisis plans. There's a whole set of training for that, and I want you to go to that training if you haven't done so already, and if you have more questions about that safety crisis plan assessment or plan, I'm finished with this. So, safety crisis plan, what is it? Well, risk assessment and mitigation plan for behavioral issues. It helps family and staff respond in a planned manner to reduce the possible impact of a crisis situation. So we're really trying to figure out what's going to need to happen if we get into a crisis situation around behavioral issues, when to call, what to do to prevent, to alleviate the situation, and what to do afterwards to keep things calm and de-escalate. So who needs a safety crisis plan? Well, who's likely to have a behavioral crisis. That's like similar to a event in the case of a hurricane, or in the case of fires. You wait until you have one to create it. You do it beforehand. So anyone who's likely to have a hurricane should have a plan for what's going to do during a hurricane. All of us should have fire escape plans, and we should know we might need a behavioral crisis plan if possible, and have that ahead of time. So who does a safety crisis plan? Well, a plan is created by the planning team. If there's a licensed behavior analyst as part of that team, then he or she might take the lead, because it should be consistent with behavioral principles. And teams who have licensed behavior analysts should always be part of developing the content of the individual support plans and, of course, the safety crisis plan, because they're the ones that are going to have to use it. You medical professionals, such as the community RN, to review plans, make sure there are no contraindications or special things to consider. So it would be things like if you have somebody with brittle bone syndrome and you need to use a physical crisis management procedure, then the community RN could review those possible procedures that are in your curriculum and say, this one is okay, that one is not okay. Diabetes, and how long can they be set before you have to offer them food might be part of what's in your safety crisis plan. Where is this safety crisis plan? If there's no behavior support plan, it's part of the individual support plan. If there is a behavior support plan, it's part of what's in the behavioral support plan. So that's the physical location of that safety crisis plan. Go to this question. I have a question about, do support coordinators obtain the informed consent to conduct a functional behavioral assessment if the team decides one is needed? So you're going to get a functional behavioral assessment. You have to secure behavioral services. So my question to you would be, if the support, well, first, guardian should be part of the planning team that says, yes, we need a functional behavioral assessment, or yes, we need physical therapy services, or whatever other kind of services you might secure. So hopefully they've been part of that discussion ahead of time, part of that planning team, and they've already given consent. But they're going to have to do the choice of provider when you have behavioral service being requested. And they're going to say, yes, I agree to this service before you request the service. So it's not, the answer to that is yes, the support coordinator would have to do that, because it's the support coordinator's job to secure the services and to do that request for it. So then, once there are behavioral services secured, the behavior analyst or the qualified behavioral health professional will be working with the support coordinator to get kind of consent regarding the strategies within the plan that they develop. But securing the services require consent and choice by that guardian, and that's the support coordinator's role. Okay, so the safety crisis plan is our polling question right now. I said that I don't have it in A and B and C, so do that, Heike. I guess they one's correct.
Pause. Well, actually, I think we got ahead of ourselves. I think, if I remember correctly, this is one that got the polling question coloring.
Oh, yeah.
That's really not the question.
Sorry, this was my error. It's not really the question, but since you're already answering it, okay. I don't know what the question is. Who writes the safety crisis plan? And that's the one that's being polled. So that's fine. All right. I confused ourselves here. I confused her by happy indicated pink, and it's not really the question. So she poked the button that made the question appear, which is a little ahead of ourselves. Basically, you know what a safety crisis plan is. Okay, go to the next slide. We have the responsibilities of the provider and service coordinator in the safety crisis plan. So both of them, the service coordinator, which make up the planning team, with other individuals, should be recognizing the situations in which a safety crisis plan might be indicated and the situations in which it's required. They should ensure that there are ongoing implementation of positive proactive approaches. They ensure that procedures that are used are both least restrictive and within safety parameters. And they should identify the specific criteria and procedures to be used if there is a physical restraint, timeout are included in the plan, which includes ensuring guardian and individual consent and incorporating the safety crisis plan into the ISP. Which you already answered. Who writes the safety crisis plan? There are no behavioral services in place. Choose all that apply to this question. So the planning team is the correct answer for this question as who writes the plan. Now, physically puts it down on paper, that is the support coordinator, but the team is involved in developing the plan. So it's the responsibility of the planning team to develop it. It's the responsibility of the support coordinator to write it down. So what's in this directive is information about chemical restraints and are utilizing the definition of chemical restraints that is in CSR and as well as in Centers for Medicaid Services definitions. As my favorite definition, and there's always extensive discussion about is this or is it not a chemical restraint, and what I'm going to tell you is that look at the letter of the law here, look at the letter of the definition, and not what you think is right or wrong, or whether you think it's a restraint or not. Follow definition, and that should help you in determining is something a chemical restraint. So a chemical restraint, whether it's a prescription medication or an over-the-counter medication, anyone who's receiving services that we fund is considered something that's administered with the primary intent of bringing a patient who presents a likelihood of serious physical injury to himself or others. Okay, so there are several important parts of this definition, and again, as I said, it's not my favorite definition, it's not the way that I would write it, but it's have to use. So it's given to the person. The purpose of it is to restrain the person, make it so that they're less likely or less able to move, if you consider the definition of restrain, because they have a likelihood of serious physical injury to themselves or others. So there's three parts to that have to be true in order for it to be considered a chemical restraint. It's also something that's not prescribed to treat a person's medical condition. So they have serious seizures. When they take their seizure medication, it makes them drowsy, and they usually take a nap. It's not a primary intent to restrain a person. The primary intent of that seizure medication is to treat the seizures. A person not presenting a serious likelihood of injury to themselves or others, and that's why the medication was given. No, they were given medication to prevent seizures. So that example does not meet the definition of chemical restraint, even though the person often takes a nap after taking it, because that medication for seizure medications was given to treat a medical condition. This is a medication that's given in response to an emergency situation, and the intention of that medication is to control their behavior. Okay, so chemicals versus psychotropic PRNs. Sometimes a psychotropic PRN is also a chemical restraint. Sometimes a chemical restraint could be something that's not a psychotropic medication. So again, think about the three conditions that have to be met. So according to the definition is vague, the following: a psychotropic PRN, a reactive strategy, and a restrictive intervention. Use of this reactive strategy should suggest, and if you meet criteria, may require additional consultation. If it's a restrictive intervention, it has to be justified in the individual's ISP, even though it's prescribed by a physician. The team still needs to put the rationale for its need in the ISP, and they also have to assure that they've considered that this medication, to the best of their information, is going to cause no harm to the individual. We have to do according to statute. I have a question, and I'm going to talk that through with you all in a minute. So, friends, this means needed medications are prescribed by physicians, usually at the request of people who are supporting the individual, sometimes at the request of the individual or because of the symptoms individuals presenting. But what you're not giving it regularly. So part of their daily medication, it's just for specific situations. And these need to be clearly defined, especially when we have support staff that are responsible for identifying that the person needs this medication. We need to clearly specify for them when those situations are. And so saying something like when they're agitated is not very clear, because agitated to me and agitated to you and agitated to Heike could all be different things. So we clearly specify what agitated looks like for this individual. We all need to clarify the effects on the person when the PRN is given. We need to look at what happens. And if it tends to make them unable to move, unable to respond typically, we consider whether it's possibly a chemical restraint. It makes the person unable to function in their typical environment, it's probably a chemical restraint. No matter what medication it is or how it's administered. So it doesn't have to be an IM injection. It could be something that they take by mouth, and it still could be a chemical restraint. A PRN might be a chemical restraint if it disables the person and makes them unable to function as they would in their typical environment. So it's a chemical restraint. So here's your question: how would you classify the following example of use of as needed or PRN medication? Someone very upset, hyperventilates, and fights someone around them when they're going to the gynecologist, is given PRN Ativan. Of course, it was prescribed by the gynecologist for use. They're given PRN Ativan when they go to those appointments. When they're home, they function okay, and they can also get through the doctor appointment without too much trauma. How do you classify that? Is it a PRN? It is a PRN, but is it also a chemical restraint? Okay, so almost everyone got this correct. It is not a chemical restraint. So because they're getting through the doctor appointment and they come home and function okay, it is not a chemical restraint. Remember, the definition of chemical restraint is its intent is to address a problem, behavior that's going to be dangerous to the self or others, and immobilize the person, and that's what happens is they are immobilized. So that answer is A. Okay. So of the service coordinator or support coordinator with respect to chemical restraints. Well, chemical restraints are restrictive interventions. Restrictive interventions must be justified. The rationale must be described in the ISP. Physician's order that can be written for no longer than 3 hours. So it can't be, if it's a chemical restraint, you can't have it as a PRN. In other words, you can't have a physician write the order that says, anytime you see this happening, give them this medication, so PRN, and the medication is going to really, in essence, immobilize them for a time. It ordered within the time frame of the need. So they are currently about to exhibit some potentially dangerous behavior. The physician has to order it at that time. The order must be in the individual's record and contain specific information indicated in the directive. So why you would need it, all the things you need to do to monitor it. So again, it cannot be a PRN. If it's going to be a chemical restraint, it cannot be a PRN. There has to be ongoing visual observation of the individual, and some safety checks need to occur. They need to be breathing. They need to be, they can't have vomited because they are at taking risk then. So you have to do some ongoing visual observation if you administer a chemical restraint, or if your person has a chemical restraint and you're serving them. Medical professional, so this could be the person's nurse, the community RN, and it could be the physician, must observe the individual within 30 minutes of administration. This must be documented as indicated in the directive. So, as you can see, it's unlikely that most community service providers are going to be able to utilize the chemical restraint because they're not going to be able to meet these requirements as specified. And that's okay. That's done purposefully. We don't want people being chemically restrained. This is onerous and difficult to do on purpose for the person's safety. So we have a question, are anxiety, depression, agitated depression considered medical diagnoses? If a psychotropic PRN actually helps the individual participate in the milieu, it's chemical restraint. So definition of chemical restraint, if it doesn't immobilize the person and the intent isn't to immobilize the person, and they can get through their typical activities, then it would not be a chemical restraint. It would just be a PRN. Now, I will say that those diagnoses, I'm not their medical, is something you have to ask a doctor. I'm not a physician. Actually, I'm not going to say doctor. I'm going to have to ask a physician. I'm not a physician. I don't consider those specific enough to know when to administer them. So I want to know what symptoms or behaviors are happening that tell me the person is agitated. Anxiety that would tell me when I'm supposed to administer that PRN for the person. But if the person can get through the day, they're not exhibiting dangerous behavior for themselves or others, and that's why you've administered the medication, then it would not be considered a chemical restraint. Okay, with applied behavior analysis and medications, I frequently get into discussions with behavior analysts about their role in medications. And almost 100% of time in behavior support plans or in functional assessments, what I see the behavior analyst document does not meet their responsibilities as an ethical behavioral service provider. So just telling me what the side effects are and what the medical diagnosis is not sufficient to an area an behavior analyst's ethical responsibilities in this situation, because we know that medications impact behavioral functions or this. So we know that there are some medications that make the person less susceptible to social reinforcement. Well, if the plan mainly utilizes social reinforcement and administered a medication, then that affects that plan is going to be less effective. So we need to know that and perhaps not just rely on social reinforcement. Some medications can make individuals less susceptible to negative reinforcement, especially associated negative reinforcement. And if you're trying to change behavior and have an individual respond to negative social reinforcement, their behavior change mechanisms, and they're taking a medication that makes them less susceptible to that plan's going to be less effective. So you need to know that. So those are just a couple of examples from behavioral pharmacology that behavior analysts should be familiar with. And so we want to follow, as we're the measurement experts in this team. We are the people who are utilizing and arranging behavioral principles, strategies to affect behavior. Well, then we need to look at what behaviors those medications are supposed to be affecting and see if they do, in fact, make changes in that direction. So we need to know what are the symptoms of anxiety for an individual and be part of what we're measuring in our plan, because we know they can affect our strategies. So we need to review and appraise the effects of any treatment, including medications, and see if they impact the goals of the behavior change program. And you can't do that unless you're measuring those symptoms. As greatest extent possible, not just the side effects, but the effects of the medication, what the medication is prescribed for. To have target behaviors for those, and we need to be in communication with the team and the prescribing physician about the effects of the medication. Okay. We have determined those things during the functional behavioral assessment. We hope so. It could be possible that the medications happen after the functional assessment and you're brought on it late, so your measurement starts after the medications have already been administered and maybe even for a bit of time. I know what reality looks like, and that's why it says to the extent possible, as soon as you know about it, the behavior plan needs to change to include those target behaviors if they aren't already there, something that we measure. So that's a very good question, and I should hope that you've identified that in the functional assessment, but in case you missed it or in case the medications change afterwards, then you would pick that up at that time. Okay, so now about the behavior support plan. So we'll go through a few of the things that we identified as best practice for behavior support plans. If you're not a behavioral service provider, this is in the way of education so that you can be aware as an informed consumer, because everyone who's involved in that behavior support plan implementation process is a consumer of that plan. Our behavior analysts have a lot of stakeholders that they have to answer to, including the individual whose behavior is the target of change. As we all know, every individual around that person is also going to have to change in order to implement the plan correctly. But what are parts of the plan? The responsibilities, first the responsibilities. The responsibilities of the support coordinator is to write an addendum in the individual support plan to ensure that the service, when it's requested, has identified need and goal specified. Also submit to utilization review the request for services as designed by a behavioral professional. So that's going to require contacting the behavioral professional ahead of time and saying, brief of the problem, how many units of what services should I request? And then the support coordinator is responsible to monitor to see if those services are provided. Is the behavior up as they were requested to, as they designed the services to do, in being implemented by everyone who's supposed to be doing it. So do they see the strategies being used? And also the support coordinator is an extra check to see if it's working. So hopefully the behavioral service provider has that as their primary objective, and they are monitoring and seeing if the plan is working and changing it as it happens. But the support coordinator is really the advocate for the individual to get what they need, and part of that is to see if what they're getting works. So they're looking to see if it works. The support coordinator does not write or rewrite behavior support plans into the ISP. The whole document created by the behavior service provider becomes the plan, not a rewritten document by the support coordinator. That's not their responsibility. So those are the responsibilities of the support coordinator. Also, the support coordinator contributes to the development of the strategies in the BSP as part of the discussion, as part of the planning team. They give feedback to the behavioral professional who's developing the behavior support plan as they have things to assist with. And they also may be part of implementing the behavioral support plan and at least ensuring that expectation of implementing with fidelity is and funded by all of the other support providers on the planning team. Okay, abilities of the providers of behavioral services, so that behavioral service professional, they must be licensed and they must work in collaboration with the individual support team. So contextual fit of the strategy in the plan is a very important part of making plans effective. And just because you really like token economies and you're really good at writing those plans doesn't mean you should use them in every system that you work in if it doesn't fit within that system. So that's just an example. The behavioral service provider works in collaboration with the individual support team. The techniques included in the plan should be based on the functional assessment of the target behaviors. And those techniques must meet the requirements for practice of applied behavior analysis under our rules. So I've identified what those are. So specific elements of behavior support plans can include the following information that can be understood and consistently carried out by family or staff. So these are the things that are identified as required practice for behavior analysts. They plan to include proactive strategies that will serve to prevent challenging behaviors. They should improve the quality of life of the individual, and they should promote desirable behaviors. They include a teaching plan for functionally equivalent or related behaviors that will replace the challenging behavior. So this could include communication skills. It could include things to help the person get through a problem situation like loud noises or angry roommates. It includes things that make the individual more independent and develop community skills so they can be more successful in their life. That's part of quality of life. And they include identifying behaviors that are related to the symptoms for which psychotropic medications were prescribed. some other of the plan are that, again, that can be understood and carried out by family and staff. It should include data collection and new plan that when the plan and the data will be reviewed to progress, very assess fidelity of the intervention. So are the strategies being used as designed, and that communicate the progress to the individual support team, including the prescribing physician. The physician can choose whether or not to look at it, but that doesn't mean we don't present the information. So that data collection part is both the behaviors for the individual and fidelity of implementation. So working and people doing it as you designed. Those are two different kinds of data that need to be collected. And plan should specify strategies to generalize and maintain the progress once the behavior support plan and behavior services are faded. They also include the following information, again, in a way that can be understood and carried out by family or staff. Safety crisis plan, if it's necessary. Physical restraint, this is manual holds, because we do not allow mechanical restraints in Missouri. That's a prohibited practice. Are in the person's safety crisis plan, then the specific criteria should be identified, and possible procedure should be identified, including monitoring the person's health status every 15 minutes. Procedures are in use, and time might be never more than an hour in duration. Should also in the plan include justification for that level of restriction and indications that this is the least restrictive possible strategy that could be used and the most likely to be effective. Staff need to be competency trained. This means more than just reading the plan and more than just reading the plan to them. There needs to be a oversight of implementation of the plan. So we need to see that people can do those strategies. So I'm going to stop for a minute and take a drink and see if there are any questions around the behavior support plan or behavioral services that you all might have. Okay. See any questions about behavioral services or behavior support plans? So I'm going to move on to the Regional Behavior Support Review Committee. Currently 4 Regional Behavior Support Review Committees in the state. If you don't know of a review committee in your region, but you access some consultation by a review committee, you contact the area behavior analyst for which you practice, and they will get your strategies reviewed by the closest committee. So even though there are only 4, we can't do everything statewide through that process. There are the committees are purposefully made up only of licensed behavioral providers because what they're reviewing are things that are relevant to behavioral services. They, because the person does not have behavioral services, be reviewing individual support plans, but they're doing it with that perspective of understanding and behavior analysis. If we have a situation where medical expertise is required, we can have an ad hoc committee member who medical expert to participate in that discussion. And always the individual's support team is invited and requested to attend the meeting in which plans are discussed, and so they become members of that review committee during that discussion. Okay, committees, the review criteria for who will be invited to the committee by the person is in each region according to the region's needs and based on who having high-risk outcomes in region. So it's based on that data that's reviewed and collected and asked by the area behavior analyst, and they prioritize individuals with the most challenging behaviors, the restrictive interventions, and the most high-risk outcomes. And they individuals. At this point in time, it's invitation, which means that you can participate if you're invited. However, at the point in time where the rule is no longer a draft rule and it is promulgated and becomes law, that invitation is going to be mandatory for individuals who meet certain criteria. So that's something to pay attention to now. Who's prioritized on this list is decided upon by the regional committee and area behavior analyst based on issues and capacity. The committee has a consultative function, and that is specified in the directive and the rule. They are there to consult and try to assist planning teams in better supporting individuals, more successfully supporting individuals. So they're not approving, they're not sanctioning, they're not scolding, they're not doing those kinds of things that have absolutely nothing to do with the UR process. They're really consulting that support team in serving and supporting the individual. Okay. They're not reviewing all individuals with restrictive interventions. They're not reviewing all individuals who have reactive strategies. They will review anyone who requests assistance. So anyone who refers so any person who's referred and requests review, they will review. They're reviewing all individuals with challenging behaviors. Nearly 40% of individuals served in our system have some level of challenging behaviors that would be impossible and not a mandate. And not reviewing all individuals with behavioral services. So my hope is all 40% of those individuals end up with behavioral services, so certainly we wouldn't be able to review them all. The committee has other mandates, as we just discussed previously. Okay. Here's a polling question. When mandated that services in a plan be reviewed at the Regional Behavior Support Review Committee? Mandated that services in a plan be reviewed at the Regional Behavior Support Review Committee. So the mandated is C. And so timeout is used by support staff or included in the behavior support plan. Have a request when there are restrictive strategies in place, but unless you meet the threshold for review, you would not to be reviewed. So the threshold for review, not just the threshold for review by the committee, not just the threshold for planning team review. So you could answer B or C, and would consider that correct, but it's not all of the above. 14% of you answered that one correctly. So let's see, times for review. We were developing this directive and draft rule. There was a request that we put in timelines to make sure that the responsibilities of the and the area behavior analysts are clearly specified. And so there are some timelines in the directive and the draft rule for the committee. And one of them is that when somebody's referred or requested to have their planning team and supports be reviewed by the committee, that the committee will meet that request within 30 days of receipt of the request. So the committee will review with days of being requested to attend the committee. There will provide a written summary to the support coordinator and provider within 5 working days of review. So you'll know you've been at the meeting and heard the discussion and been part of the discussion. You'll also receive a written summary of that discussion within 5 days of review. And another thing that's specified is that the Regional Behavior Support Review Committee is separate from the process committee, and one does not depend on the decision of the other. These two are separate independent committees on purpose. They're reviewing different things, and they're reviewing the strategies for different purposes. And so one review does not depend on the other. Although the Behavior Support Review Committee might recommend that due process needs to occur in this case and review by the due process committee. Again, those are two separate things. Or due process committee might say, it looks like due process was met here, but we recommend you get some assistance by through the review committee, the Regional Behavior Support Review Committee. So they refer to each other, but they're not dependent on each other. So this concludes my presentation of the second part of the directive and draft rule. We've got 4 more minutes, so if there are any questions that were not answered by this presentation, you have some time now to ask them, and I would answer as I can. Okay, for another 4 minutes. If you don't have questions and you need to, you can log out of the session and a survey come up. Please answer that survey. Again, if someone sees a psychotropic PRN, does that need to have an event report? So I believe that's a reportable event, but you might check through the reportable event criteria in Directive on Reportable Events and make sure that's true. But as to that, again, my answers and my information does not take the place of reading that information yourself in the directives or rules. Let's see, a question is, important. Okay, but I'll answer it again. Do support coordinators obtain informed consent to conduct an FB or write a BSP if the team decides one is needed, or can the team decide themselves? Okay, so there are multi-layers in that question. First of all, the guardian should be part of that support team and part of that discussion, and so they understood that the rest of the team feels it's necessary, and they would have worked out within if they're going to request services. We do not provide services that the guardian doesn't agree to, and agreeing to the services would happen before you request them, and so the support coordinator would get that informed consent from the guardian to move forward and request those services. So a team can't override the guardian. On new guidelines, will a Depo-Provera shot for a male individual still be allowed on a regular basis? A Depo-Provera shot would be something that's prescribed by a physician for some medical purpose, and assuming that it doesn't immobilize or incapacitate the person from daily functioning, it would not meet the definition of chemical restraint. I don't know that I would recommend it. I don't know that it's the least restrictive strategy in place, and I don't know that it's actually addressing the individual's needs. So all of those questions would be needed to be answered in terms of using that. Does the plan continue after the behavior analyst no longer works with the team? Okay, that's a really good question. So the answer to that is a behavior plan is like a prescription from a physician. If the physician is no longer involved with the individual, you're going to renew that prescription. In other words, they're not going to keep writing you a prescription once they don't see you anymore. A behavior support plan, behavioral service provider should be working to get themselves business with that individual and raising that plan and those strategies as they are more and more effective, so that they're also fading out the need for those specialized strategies. And eventually the person is supported successfully, just typical strategies that we include in individual support plans. So that's the long answer, and the short answer is if there's no behavioral service provider, there's no behavioral support plan. That plan becomes obsolete. Okay, who is responsible for tracking reactive strategies? I think I found this in the beginning, that the people using those strategies, the support provider whose staff are using those strategies, is responsible for tracking them. If they're reportable events, we should be getting incidents reports on them, and we can track those reportable events. But if you're implementing restrictive, reactive strategies, if your staff are using them, if you're part of a support plan, support or team in which those are being used, it's the support and planning team's responsibility to track them. We are out of time. Please fill out the survey at the end when you log off, and thank you for your participation today.